Okay, everyone. I think the lights have gone up, haven't they? So that's our cue to start. And again, good morning, everyone, and welcome to day 3 of Hospice UK conference. It's really lovely to see all of you here this morning and to welcome you to what I know is going to be a really interesting and exciting session this morning. So my name is Anita Hayes. I'm Head of Clinical Leadership at Hospice UK, and absolutely delighted to be chairing today's session and co-chairing today's session with Dr Julie Kinley, who's the clinical lead for evidence and research at Hospice UK, and is going to be introducing our panel today. Just a few housekeeping notices and particularly also like to welcome all the colleagues who are joining online this morning, and also to say that this session will be available online 10 days later, 10 days from now, on the online platform, and there are details in your conference brochure about how to access that. So for those colleagues that are watching us online this morning, please do put your questions for the panel into the Q&A section underneath the live stream, and we would really encourage lots of questions this morning. There are some standing mics in the room as well, but we will anticipate questions coming through on the Slido, and I think the Slido QR code's just gone up behind me on the screen, so take account of that and do put your questions into Slido. We've got plenty of time for that conversation a little later on this morning. Just also like to encourage you to turn your phones onto silent because they do interfere with our speakers in the room, and we're not expecting a fire alarm this morning, so if we do have one, we will be shown to the exit point, and we'll be mustering just opposite the courtyard by the Leonardo Hotel. Getting on your nerves, neurological conditions and palliative care. And I am so delighted that we're joined by an amazing panel today. And as you can see, I think we have not all the members of the multidisciplinary team, but many here, which is just amazing. So we're going to be welcoming everyone to the session this morning and really looking forward to the conversation. So we're going to be starting with a short presentation, and I would like to introduce Dr Idris Baker, who's the National Clinical Lead for Palliative and End-of-Life Care in Wales. And Idris is a consultant in palliative medicine at Tai Olwyn in Swansea, and working mainly in community palliative care, and holds honorary appointments at the Universities of Swansea, Cardiff and Amsterdam. And Idris is the National Clinical Lead for Palliative and End-of-Life Care, working in Wales, and is also part of the new National Clinical Programme. And the programme is designed around the principles of value-based healthcare and aims to deliver quality of palliative and end-of-life care across Wales and across all ages, and also across our statutory and voluntary sectors. So Idris, welcome, and thank you for joining us this morning. Thank you.
Good morning. Thank you for the welcome. It's always useful to have a reminder on Tuesday morning of what I'm meant to be doing with my life, isn't it? But thank you for, and thank you in anticipation for my colleagues on the panel this morning. We're really so delighted to have been able to put together such an interesting discussion. And to that end, I'm going to speak really very briefly just to introduce what we're looking at, so that we can leave plenty of time to hear from them and plenty of time also for the conversation, which we hope will ensue from this. But I just want to give a little bit of an overview of the role of hospices and palliative care more widely in supporting people living with neurological conditions. And as you know, this has been a long-standing part of hospice and palliative care practice, really for as long as the modern hospice movement has existed in the UK. The records of St Christopher's Hospice record that really in its early months, among the patients admitted to the hospice were some people living with neurological conditions, including motor neuron disease and multiple sclerosis. So really this is something that the hospice movement has always had some involvement in. And moving forward more recently, you may be aware, the European Association for Palliative Care and the European Academy of Neurology 7 years ago published a consensus statement on the role of palliative care teams, including hospices, in supporting people, saying that palliative care teams should be core in the MDTs supporting people with neurological conditions, and that referral to specialist services, including hospices, should be considered early in the progression of people with neurological conditions. So this is not a new idea. In some countries, particularly those countries in the developed world where the specialty of palliative care has been maybe less comprehensively developed, neuropalliation has become a growing field in the medical profession, particularly with neurologists getting training not only in neurology but in palliative care to combine those two sets of skills so as to be able to support some of these patients. And we could think, of course, of a whole range of conditions, and we're going to hear a little bit later in this session about some of the conditions that might fit to seem really very precisely what we think the hospice and palliative care movement is meant to be about. Most of my own clinical experience day-to-day in neuropalliation is with people with motor neuron disease. We have an integrated South Wales motor neuron disease care network, which serves a population of about 2.3 million people, and which embeds that palliative care approach, but also access to palliative care specialists, including in hospices, really from the very early stages of people's progression with motor neuron disease. Interestingly, of the 12 local MND clinics that the network runs across South Wales, 3 are hosted by voluntary hospices. And I don't know about you, I hear people say sometimes, well, we can't refer them to the hospice, they might not want to go. We can't have an outpatient clinic in a hospice, they might not want to go to it, they might be a bit scared. We've had in 11 years of operating that network, not yet one refusal. Not yet one person who said, well, I don't want to go to a clinic in a hospice. I think it depends how you sell it, doesn't it? And what we tell them is, well, the hospice is part of the team, and the hospice is where we do the clinic. In your part of the world, in other places, it might be done in the hospital outpatient department, but here we do it in the hospice, and that's where the team would like to see you, because that's where we can assemble the skills to deal with some of your problems. And they say, thank you very much, and they come. So I'm a little bit skeptical about the need for reluctance if we get the message right. But there are lots of other conditions, and we'll hear about some of them. There's been written work for now decades, I think, about the role of hospices in supporting people with some forms of multiple sclerosis. As I say, St. Christopher's was involved in that very early on. And particularly the primary progressive form of MS and perhaps secondary progression as well. Some people with progressive Parkinson's, with multiple system atrophy, with PSP, progressive supranuclear palsy, there's a tongue twister. Huntington's disease, you may have families experiencing Huntington's in your part of the world as I do in mine. People with corticobasal syndrome, muscular dystrophy, these are some of the conditions that you'll see and you may have experience of. And of course, muscular dystrophy, the last of those, there may be particular transition needs with younger men now living much longer into adulthood than was expected when some of the children's hospices services were first set up, and that's changed how we need to do things. There are various triggers proposed in the literature for when a palliative care approach or a hospice referral might need to be considered. For some conditions, perhaps at diagnosis. Well, that generates the question about whether you're now deviating from a needs-based approach to a diagnosis-based approach, perhaps paradoxically for a group that's been underserved. Maybe it's at the onset of symptoms or psychosocial problems, as it would be with cancer or so many other illnesses, perhaps when needing to consider an intervention, a procedure of some sort. Maybe we need the decisional support that hospices excel in supporting those decisions, perhaps when someone's deteriorating, perhaps approaching the end of life, perhaps when a family needs support in bereavement. There may be a role for referral even where a hospice hasn't previously been engaged. So a number of triggers have been proposed, and we may have the opportunity to explore some of those during the course of this morning. The reasons for all of that, I think, being obvious. The expertise that hospices as well as other parts of the wider palliative care world, may bring to these conditions. In symptom control, the conditions I listed, there's only one exception. It's a rare illness, but for all of the others, the majority of people experience significant pain during their illness. It may not be listed in the textbooks as a cardinal symptom, but the majority of people will have pain at some point. The expertise in other symptoms, the expertise in some of the non-physical manifestations, and again we'll hear during this session about the manifestations of some of those. These are all things where hospices are ideally placed, are they not, to offer the support in which you excel. But we sometimes encounter some reluctance, and again, we'll have some opportunity to explore that. And I think I'm probably not alone sometimes in feeling, when I get a referral for an obscure neurological condition, in feeling, well, I won't know what to do. I don't know enough about this condition. Most of us feel a little bit rusty. I think this is not only in the medical profession, with some of the more obscure parts of neurology. And of course, some of what is needed by people with some neurological conditions does rely on that neurology-specific or even disease-specific expertise. And so working together, we have to find ways to use and deploy that expertise as we work together across disciplines, across professions. But I've got to tell you, this is the encouraging thing I've learned, and I think it's the big takeaway for me as we've been thinking about this session is, you know what, most of it doesn't rely on that special knowledge. Most of it is about taking what we know and what we do well and doing it well for this group of people. I reckon about 2/3 of what we need to know and what we need to have the ability to do, the skills we need to deploy, is actually quite generic and transferable once you know that you're working in a team that can plug in the other bits, the more specific bits. And the results of doing that and doing it systematically and doing it well and working together to do it are, we often find, hugely rewarding, in fact, as we pull together to do what we can do well for this particular group of people who otherwise may not always get the support we need. So I'm going to stop there, and we're going to hear from some people who have important, I think, and useful things to say about this bit of work. Thank you.
Idris, thank you very much for that introduction. You've set us off on a really great platform for the rest of the event this morning. It gives me great pleasure to introduce Chris and Kate Thurston next. Chris is living with motor neurone disease, having been diagnosed in 2017. He works as a chartered surveyor. It turns out in Liverpool. I didn't know that until this morning. He was a keen amateur sportsman prior to diagnosis, participating in football and distance running. He lives in Ellesmere Port with his wife and 2 children aged 13 and 10 years old. Kate is the wife of Chris, and they've been married for 14 years. She actually works as a specialist nurse in immunotherapy at Clatterbridge Cancer Centre, as well as caring for Chris and their 2 children. You've got a very busy life. Welcome.
Thank you.
Hi everyone. My name's Chris. This is my wife Kate. We've been asked to talk about our experience of hospice care and how this has helped us to live with motor neurone disease. I thought I would start by giving you a brief background. I was diagnosed with MND in 2017. Initially, I presented with a mild foot drop, which I noticed whilst I was playing football. I was reviewed by my GP, and they suggested a neurology opinion. The waiting list was over 12 months, so I arranged a private consultation as I had a healthcare cover through my work. Various investigations and scans. After ruling out other possible differentials, I was told, unfortunately, my diagnosis was MND. At that stage, I was fit and healthy. I'd run a marathon, and apart from the foot drop, I was relatively well, and had little previous experience of accessing the healthcare system. I was living with my wife and 2 young children, doing well in my career as a chartered surveyor. So to be given a diagnosis like this with no treatment or cure was completely overwhelming, and I didn't really know where to turn. At this point, I was referred to my local neurology centre. We found the consultations there to be very clinical. Due to my relatively good health, I did not have input from other services at this point. We did feel quite alone at that time. Didn't really know what to expect in terms of support. It was a tough couple of years for us, learning to navigate the condition, and at times we felt like we were really on our own. After a couple of years, a referral to the local hospice in Chester was suggested, which we agreed to, but we had limited experience of hospice care. We weren't sure what to expect. My first involvement with the hospice was through complementary therapy sessions. They included reflexology, massage, aromatherapy, which wasn't something I'd had any experience of before. I was introduced to a really nice lady called Debbie, and we hit it off straight away. I immediately felt comfortable. I found the environment very welcoming. In addition to the therapy element, it was really nice to have someone to talk to and someone who was happy to listen. Shortly after my first contact, an appointment with the palliative care consultant was arranged. This was a really positive appointment. For the first time, many of my issues, both physically and psychologically, were addressed. The assessment was very detailed and holistic, covering a broad range of topics that had not been previously addressed. I felt comfortable to talk honestly. I felt the time was a no-issue doctor. It was the first time I felt properly listened to since my diagnosis. Both Kate and myself came out of the consultation feeling that someone was invested in us and wanted to help. These appointments really filled in the gaps from the MND clinic visits. The palliative consultant proceeded to action any issue identified at the consultation, including liaising with and updating my GP regarding medication changes. This has not been done previously. We had not realized that many of the services we assumed would be provided at the MND clinic were actually facilitated by the hospice team. Having had no physiotherapy input for the first years of MND, it was a relief to find that this was available both at the hospice and by way of home visits. The hospice physio team introduced the idea of using a walking frame or wheelchair by bringing this equipment to our home, but without ever being pushy. They were able to strike a balance using their knowledge and experience of the disease to guide us and try and stay ahead of the progression. We've so appreciated this service as it filled the gap that had been noticeable since my diagnosis. At one point, physio had been suggested by our specialist MND clinic, although a referral was placed with our local neurophysio service. We were told after several months of waiting that this was rejected straight away. The reason we were given was that there was a lack of rehabilitation potential in MND patients. You can imagine how this felt to us. And actually, in my experience, physiotherapy has been incredibly beneficial to us, as it has helped me to keep some mobility and maintain my functionality. I would argue that regardless of rehab potential, physiotherapy is a pivotal aspect of MND care. The next hurdle came when we needed to start thinking about home adaptations, i.e. downstairs living. This was a very overwhelming prospect. We didn't know where to start. The hospice team again acted as our guide, putting us in touch with the OT, who offered to provide input, which was gratefully received, as we found it difficult to obtain advice from the local authority.
As my condition has progressed, our involvement with the hospice has increased. Although we always have clear scheduled follow-up with the hospice medical team, they have always encouraged that we contact in between appointments if our needs change. This has been particularly important for us, as I'm sure you are aware, this condition, conditions such as MND, the trajectory of the condition can vary. It is reassuring to know that we have a point of contact should our care needs change, to help to prevent potential crisis point. In our experience, the MDT approach at the hospice seems to be very robust. Although each service has its own speciality, they seem to have a good understanding of each other and have strong communication links. Having a consultation with any of the MDT team, if any issues arise, these are swiftly communicated to the relevant members of the team. This has been a really positive aspect for us, as often it is difficult for us to know the best way forward. Our experience with the social work provision at the hospice has been invaluable, as this is not something that's been offered to us previously. The team used their experience to ensure that we were receiving the correct financial support, which was incredibly helpful to us, having 2 young children at home. They have also introduced the topic of continuing healthcare funding early on in our journey, as this process can be difficult to navigate. Knowing the information ahead of time and awareness of eligibility means that we are prepared for when we may reach this stage. Our hospice also runs a monthly support group specifically for people with MND and their social network. This allows time to chat with people in similar situations and has allowed us to build a support network with the MND community, which we both value. This meeting is headed by the MDT team, and sessions can be directed around topics related to MND and symptoms. Members of the team include physio, OT, nutritional nurse, speech and language therapist, dietitian, social worker, and a representative for the MNDA service. We'll often be present at these meetings, so any issues can be raised and advice sought. This is incredibly valuable and much appreciated. The hospice team have also provided opportunities for counselling services and psychological support. This is not something that we have had the opportunity to access from other sources. This has been particularly important from our experience living with this condition. Has been like a grieving process as elements of functionality are lost and aspects of our lives change beyond our control. Having someone to talk to and reflect on this situation has been invaluable. This service is also extended to carers and their families. Although this is not something that we have accessed as a family, it is reassuring to know that this is an option. In summary, we are so grateful to be involved with our local hospice. We are very comfortable there and feel that as the condition may progress, that someone will be there to support in any way, that, whether this be a practical aspect such as arranging equipment to help to stay at home for longer and live comfortably, or psychological elements helping us to navigate the burden of this disease. The hospice team have really focused on allowing us to live the best possible life with MND and play a pivotal role in keeping us positive for the future. Thank you.
Chris and Kate, I feel quite sad interrupting the clapping. I think that says a great response to such an honest and open reflection of the journey so far. So we feel very privileged to have you come and share that with us in all of its good forms and bad forms of what you've experienced over the way. And I'm going to be sure there's going to be some interesting questions that come from what you've presented about what we're doing well, and perhaps maybe what we can do better as we think forward. So thank you both very much for that. So we've got such good speakers this morning. It now gives me great pleasure to be introducing Dr Luke Feathers, who's the Medical Director at LOROS, the Leicester and Rutland Hospice. He was appointed as a consultant in 2006, having trained in Newcastle, Aberdeen, Nottingham and Leicester. He's helped develop services for patients with motor neurone disease and other neurological conditions, and with a consultant colleague offers medical support and leadership to the MND team at LOROS. The team is multi-professional, and we've heard how important that is, and includes those working for the community and acute trusts, as well as the MND Association volunteers. And alongside him, to the left, is Omina Yasmin, and she's a hospice-based motor neurone disease specialist nurse and a palliative care nurse in Leicester. She supports people diagnosed with motor neurone disease and their families from diagnosis to end of life. She's worked in palliative care for 13 years and previously worked on an acute neurological ward. Welcome, both of you. Thank you.
So thank you so much for involving us this morning to be able to share a little bit about our journey in Leicester over the last 15 years or so. We're going to talk about how we've transformed from a service that was mostly based around hospital care, and how the hospice has become the centre coordinating hub for looking after people with motor neurone disease. So I'd like to say I took this picture, but I didn't. I found this picture, and I thought rural Leicestershire's never looked so fantastic. But it encapsulated for me some of the challenges that people with a serious neurological condition might face. So the gradient's uphill. There's bends in the road. You're not quite sure what might be round the next corner. Sometimes it feels like you're quite isolated, and the signage may not be that good. And where we started just over 15 years ago, patients seen in neurology in the local service, the MND nurses then went on to support them, and they were hosted by the hospital. And as a hospice, we were involved for a few of those patients, typically in the last weeks of life, but there wasn't really access for all the other services that we might have been able to help with. And when we came together with the nurses, we did some thinking about some of the challenges that there were. Communication between the different professionals was tricky. Coordinating access to other services. There were quite a lot of crisis admissions to hospital. Some provision of equipment in a timely way was difficult. And for nurses themselves, they felt quite isolated, and so at times feeling they needed more support than they were able to get. And the idea of future care planning or thinking about what to do as things changed wasn't really embedded in any of our practice. And we thought it would be good to have a mapping day. And I suppose for us, a key learning was we couldn't do this on our own, and we needed to bring together all the interested parties. So at that point, the National Service Framework for Neurological Conditions had come out, so the commissioners were really engaged. We had GPs, we had people with MND and their families, we had the MND Association, who've been fantastic partners through this work, and we had all the specialists who you might expect involved in MND care coming together for a session to think about what the key challenges were and the solutions. So right from diagnosis, how to provide the right support for people as they were hearing the news initially. We developed some pathways around feeding tubes, so whatever kind of tube you might need, making sure that access was timely, that there was the right information, seeing a dietitian early on, having an anaesthetist available for offering sedation if needed, timely access to the ventilation team and regular assessments. One of the real highlights, and there was some sadness tinged with it, so one of the people who we worked with developed motor neuron disease, but he was able to pioneer with a friend who also had motor neuron disease, a patient support group. And so he, with some support from the hospice, with some support from the MND Association, set this group up. And that's been a real jewel in the crown for the service locally. And the baton's been passed on between people with MND, and that's still running successfully today. And finally, I think the thing that also made a real difference for the service and for people with MND was transferring the MND nursing team from the local hospital to be embedded in the hospice. And the team's grown across time, and Amina's going to talk about that a little bit in a moment. But I think being able to coordinate things with other hospice services has been great. Where we are now, we have a fortnightly MDT. So most of the people come in person, a few people dial in, comprising all the kinds of professionals who you'd expect might be able to support people with MND. And we then have a fortnightly clinic where some of those professionals stay and see patients, and the team are also able to see people at home in between times as needed. So we've come on quite a journey, and I suppose I'm hoping that maybe we'll be able to give you some thinking points, inspire you to think about how your service is organised, where might you be able to do things differently. I'm going to hand over to my terrific colleague, Omina. She didn't tell me to say that, but I think it fits for her. And she's going to talk a little bit about how she's got to become an MND nurse. Think about how do you develop your workforce, because MND nurses don't grow on trees. We have to grow them as services ourselves, and also think about a patient story. Thank you. Thanks,
Luke. So I feel really fortunate with how I came onto the team. I started as a neurological nurse on the acute hospital, in the acute hospital, and that's where I met my first person with motor neurone disease and the MND nurses, and we always stayed in touch. A couple of years later, I joined the inpatient unit at the local hospice. I started working with the MND team as a link nurse, so I'd see them occasionally. About a good several years into my time at being in the hospice, one of the MND nurses gave the hospice a 2-year notice period that she wanted to retire, and she'd been an MND nurse for over 20 years. So there was a real fear that all her knowledge and her skill would go when she retired. So management were really supportive. Our local Motor Neurone Disease Association were really supportive, and they developed a 2-year succession project. And that's where I came along. So I was successful. I started initially, it was 2 days a week, so splitting my time between the MND team and the inpatient unit. Working alongside the 2 MND nurses and the rest of the MDT. At the end of that 2 years, I became one of the MND nurses. So where we are now is there's myself, the other MND nurse that I was working with, she was able to retire not long after I started because it turned out she was also waiting for someone else to kind of come up and take the baton. So we've got 2 MND nurses and we also have a healthcare assistant. So what does the hospice being involved from the start look like? So we've heard from Chris about how the hospice has helped since they've got involved. This is Bob. Bob was one of our patients, a gentleman in his 70s, who his symptoms started shortly after he had retired, and it was with his speech. After several months, he was given a diagnosis of motor neurone disease. So we typically, when someone's diagnosed, we'll get the referral and we'll go out and see them at home on the first occasion. Quite a lengthy first visit. We talk about what we offer as MND nurses, what the team can offer, so both in the hospice, in the community, and what the acute team in the hospital can offer. It was daunting for Bob for that first phone call to say that a hospice team was going to come, but I think Idris is quite right. Bob was quite willing to accept the services, and I think a lot of it is how it's said to the patient and their willingness to take that up. So we've not had anybody not want to have our services. So when we first saw Bob, we did quite a few referrals following what he'd said that he was struggling with. So for Bob, he had community physiotherapists coming out to see him, and we're really lucky that we work with a team that don't reject our referrals. I think it's really keen that they know that the referral is coming from a specialist nurse and the right information is given. A speech and language therapist also saw him, and his introduction to the hospice was through complementary therapy, and that's how we get a lot of our patients to first come in. Bob, 6 months into his diagnosis, so we carried on seeing him, mixture of seeing him at home and in clinics in the MND clinic. He had deteriorated. We'd noticed he was having some early respiratory failure signs, so we referred him to the local respiratory nurses, and at that point Bob needed a ventilation machine, which he got on really well with. At the same time as needed the ventilation machine, we started thinking ahead about what else he may need, and Bob was really keen in wanting to think ahead. And we know with MND and a lot of progressive conditions, it takes time to get things in place, so sometimes you have to start introducing ideas, several weeks, possibly a good few months before it's actually needed. So the other thing we'd started discussing was feeding tubes. So we're really lucky we've got a fantastic specialist dietitian team in the community who will go out and do what we call a show and tell, which is they'll take out all the different types of feeding tubes, show the patient what the tubes are like, let them have a feel of it, answer any questions, and then patients will come back and let us know what their thoughts are. We'll bring them into clinic, and Bob had decided that he did want a feeding tube. So we had that and the ventilation that started within 6 months of diagnosis. He was quite settled for a period after, and then a good year into his diagnosis, started to deteriorate again with his mobility. For Bob, the loss of his mobility was a huge thing because he was, prior to his MND diagnosis, a marathon runner, a cyclist. Being outdoors was all he'd ever done. He was an engineer, so the longer we got to know him, and hear about how proud he was of the work that he'd done. We were proud of the work that he'd done. So he was an engineer who was sent all around the world. One of his greatest achievements was he led a team of engineers to Ukraine after the Chernobyl disaster. Having MND meant that a lot of the things that he was doing before had to stop. When his mobility went, he started to spend a lot more time indoors, and that's when we noticed psychologically that was having an effect on him. So we had a discussion around, rather than focusing on the things that he couldn't do anymore, what he could do, what he was interested in, and with little encouragement, he came into day therapy at LOROS, which is probably one of our, one of the best services in the hospice, and it has so much to offer people. Bob came along at first thinking that he wouldn't be able to participate in anything, and then soon realised he loved art. He'd never done art before, and this is a picture of something that he made, which his family now continue to make cards out of, selling the cards, and raising money for the Motor Neurone Disease Association. So for him, it was really valuable. For his wife, it was really valuable, the time that he spent in the hospice to take therapy, because it gave her a bit of respite. His wife started accessing counselling, and then they also accessed the patient support group at LOROS as well, and then the MND events. That was really good. That's actually working. Okay, brilliant. So support groups at LOROS, he really enjoyed coming into. Is it still not working? Brilliant, okay. So with Bob coming to the patient support group, at this point Bob could no longer talk verbally, and coming to the group meant that he, with his iPad, could still have really meaningful conversations. So one day and it was something that I'll always remember, Bob noticed that another one of my patients was in the group and really anxious when feeding tubes were being discussed. So Bob went to this other gentleman and they went to the corner of the room. He picked up his shirt and showed him what the feeding tube looked like. The other gentleman was having a feel of it, talked about how the process was, and that it was 20 minutes, half an hour to go and have it done, and it really helped this other gentleman in making his decision. So I think it's a great thing about our patient support group, is that patients can learn from each other. Throughout the next few months, Bob went on to coming into the hospice twice. So he came in for symptom control. We managed to avoid any hospital admissions, which was great. Throughout the whole time, so we knew Bob for 2.5 years from diagnosis to the end of his life. He became so comfortable with being at LOROS, being around the staff at LOROS, that he decided his end-of-life care would be at LOROS. And he sadly, he did die on the ward, really peacefully with his family around him. I guess for me, the key things, not just with Bob, with all of our patients, is it's really important to have timely, coordinated care, and early on, meant that we could start having all those conversations, advanced care planning. That happened right from the start. And it's not just the MND nurses, I think it's our whole team that take ownership of doing that. Thank you.
Thanks. That's very helpful. And there's a couple of thoughts, one of them which has completely gone out of my head immediately. The other one was, I'm always reminded of that, you'll be aware of it, that Temmel paper from 2010 about lung cancer patients who were divided into a group with, in America, normal chemotherapy arm and early intervention with palliative care arm. And, the headline was that the palliative care group lived longer, actually. They had less chemotherapy, but they lived longer. But the bit of that paper that always interests me is that palliative care intervention group had less depression, because it kind of overcomes this idea that referral to palliative care early is all about bad news. Actually, it's not. We can overcome that reluctance sometimes and do some good work from early intervention. And my other point was thinking about a woman in her 60s, young onset dementia, who's entirely at home, and most of my contact is with her husband by telephone. But I just happened to do a video consultation one day, and I could see that she'd developed some spasticity in her leg and her right hip in particular, and it turned out it was starting to interfere with personal care and probably giving her some pain. But he hadn't really noticed. It had just been a slow progression of a change. And so if you're relying on patients or their families to notice relevant things, that's an unsafe, you need eyes on, really, I think, intermittently. Maybe not all the time, but you need somebody to see, because this whole idea of patient-initiated follow-up, I don't think is going to work for this group always.
Hi, I just want to say thank you for your input. It's just brilliant. I'm from a neuro background, so I was all over this. Just picking up on that rehab potential phrase, I think a phrase that we've been chatting about in our team that's come from our hospice is specialist palliative care needs, and using that as a barrier for access to referral. And I'm just interested in your thoughts on potentially a focus on physical specialist palliative care needs versus that psychosocial and almost therapeutic specialist palliative care needs, and whether you feel that there is too much of a focus on the physical, and if you guys have got any experience in how to create an inertia to create change in that shift.
Okay, Idris, would you like to?
It's a problem, isn't it? It's a problem. I would like to think that we've made it less of a problem in some services than it would be, but only by paying fairly careful attention to it. And at the risk of sounding provocative, if you're working in a team, if you as a service are focusing on the physical and on nothing else, give up and go home. Because it doesn't work. Or, alternatively, change it. Right? I mean, it's important, isn't it? In terms of the practical strategy, the focus I think many of us have tried to take, and you've heard this reflected, I think, in a number of the wonderful people we've heard from this morning, is to recognize that these different aspects of the person's experience are inherently interconnected. It is not that we have come along and decided that as well as the physical, we should also pay attention to some other things. They are inherently interconnected. I mean, this is not a new message, is it? Okay, but it's worth saying out loud, because some of the bean counters, some of the commissioners may not get it. So how do you translate that into practical action? Well, there are ways, and we may have an opportunity in the plenary a little bit later, quick plug, to look at some of these. There are ways to capture some of the value that is added by dealing with supporting people in a way that recognises that inherent interconnectedness, so that you're not only looking at the physical, you pursue what you value. So if you can demonstrate the value in that, and I think after 60 years we can demonstrate, the hospices are the organisations which have shown us we can, and then the rest of the system can copy them and demonstrate some of that, then it helps those who make the decisions about what to commission, what to do, how to deliver continuity, the previous question being so important in exactly this regard. Well, you pursue what you value.
Thank you very much, Idris, and thank you everyone for those questions. We are just coming to a close of this session, and I think I would like to say a huge thank you to everyone who has been with us this morning, and I think I'd just like to turn to Chris and to Kate, and thank you so much for sharing your experience with us, and for your message that this is about living well. And in order to do that, this is about having that interconnected support when you need it and where you need it. And I think that has really, really helped us this morning to think about that. And to have that challenge of actually, how do we make this work? How do we think differently, work collaboratively, and provide the very best care that we can for people affected by neurological conditions, and to do that over time when people need that. So huge thanks to everybody here, Omina, Luke, John, Julie, Idris and Kate and Chris. Thank you so much for being with us. Thank you all for bearing with the IT. And there's just one last notice, which is to say that the lunchtime session is starting a little bit earlier than advertised at 12:10. And for those attending, there will be lunch served in the room. So just to let you be aware of that. So thank you all so much for joining us.